All right. So, welcome to COSENT. I am your instructor, Brian. Glad to be here with you all on a Sunday morning. Kind of like having my own church.
EMT church.
EMT church. Let's force the members to come. Or you fail. Oh, hey, speaking of that, I was talking to Devin on the way up here. Apparently there's been a misunderstanding on the first day handout for today's class. Today's a 12-hour day. You guys know it's 8 to 8, right? Yeah, it's on the schedule. So apparently some people thought it was only to 4 or 5.
Oh,
But we're going straight to 8 o'clock tonight so we can make the hours.
right.
It's on your first day handout.
Sure it is.
I'm losing my grip.
You've cried wolf way too many times.
Damn. I was like, all right, bring it. I can sleep through your lectures for hours. All right. So we already figured out where we left off. The dirty teenagers spread meningitis to each other. The one that you're going to see the most for respiratory emergencies in EMS is COPD. That is an abbreviation you absolutely have to know. It's physically impossible to pass this class if you do not know what COPD means. And it means chronic obstructive pulmonary disease. So what that is it's a nice way of putting a whole bunch of chronic respiratory diseases under one umbrella. So basically you kind of know what you're talking about when you say COPD. Because even though there's hundreds of different diseases under COPD, it all has the same end result. You can't breathe, you'll never be able to breathe right again, and you're going to suffer and die for many years. That's what COPD means. So, happy Sunday morning note. So there's 4 main, so like 80 to 90% of COPD can be broken down into 4 major culprits. The number 1 culprit of most COPD patients is emphysema, followed by chronic bronchitis. So inside your airways and your bronchioles, you got these cute little hairy things that catch dust particles and bacteria particles and sweep it out before it gets down to your lungs and causes chronic lung infections. So chronic bronchitis, those little things are dead, they're paralyzed. They can't sweep that stuff out. So you're constantly getting infections in your bronchus. So you're sick 24/7. Black lung, like I said, we don't see it here a lot, but in areas of coal mines, it is common. Black lung is a common disease. And then on the rise in the United States, the fastest growing one is chronic asthma, which is generally an episodic disease. It's a constriction of the bronchioles and then some nice syrupy white mucus that then blocks the already constricted bronchioles, so you can get air in, but you can't get air out. It's a horrible air traffic disease. It's extremely uncomfortable. So generally it's episodic, but you lead a completely normal life until you have a trigger. You have an asthma attack, you take your medicine, or you get over it, or you die. And then you go back to living a normal life. People with chronic asthma, the bronchioles never relax. That's a problem. That's a real uncomfortable, horrible way to live the rest of your life. Because chronic means it's been going on forever, and it's never going to get better. That's chronic. As opposed to acute, which is the sudden onset. Chronic obstructive pulmonary disease will kill you. However, the statement that COPD kills everyone that gets it is not true. Some people get hit by trucks. Some people have heart attacks. Some people die of cancer. But they still have COPD when they die. And if none of those things get you, COPD will kill you. You just have a long, slow suffering until it finally does. All right, let's go take a cigarette break.
Yeah.
Now, in the last 10 years, though, they have developed some inhaled steroids and some treatments that have made COPD life much easier. It's still not good. You're still not going to go do a 18-mile walk through Disneyland for 16 hours in a day. It's not going to happen when you're in COPD. But you're at least going to live a little bit more comfortable life and longer life. If I get to play with the grandkids for a few hours before you're completely exhausted from hypoxia and hypercarbemia, it's going to have to go lie down for a while. So the medications are making life longer, without a doubt. And we're not seeing as much of it in EMS for critical emergencies like we used to. Where you'll start seeing COPD patients now is like what's happening right now when you get a big run of COVID or RSV. And so like you and I will get RSV or COVID and we'll feel like crap and we'll be tired. COPD patients, it can kill them or takes them down to the point of needing 911. Something like when you get a big fire or they're doing a ridiculous back burn like they've just done the last 2 days. That amount of smoke that comes into North County, where you've probably got about a 30% COPD population in the north part of this county. That level of smoke into people that already can't breathe is just devastating. And then you throw in some COVID on top of that or some RSV. You got people in ICU on ventilators. Any questions? So that's when you'll see it the most in EMS. But like I said, we don't see it really. We used to see it when I started as a little tyke in EMS. We get 3 or 4 COPD calls every week and 2 or 3 CHF calls. And we don't hardly ever see, we started to see CHF 3 or 4 times a year now, just because of the improvement in home medications and treatments. And we do a better job, which you're going to learn in the next slideshow, on getting cardiac patients in to get the arteries open before their heart completely dies. Now that I've just talked my cool head off endlessly about it, here's someone that actually knows what they're talking about.
Understanding chronic obstructive pulmonary disease, COPD. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it difficult to breathe. COPD is a long-term disease that often gets worse over time and is characterized by inflammation and severe limitation of airflow in and out of the lungs. COPD is an umbrella term used to describe a group of breathing conditions, the most common being chronic bronchitis and emphysema. Many people living with COPD may have both emphysema and chronic bronchitis. A few people have both asthma and COPD. Cigarette smoking is the leading cause of COPD. Long-term exposure to secondhand smoke or irritants such as air pollution, dust, or workplace fumes, and biomass exposure such as wood smoke can also contribute to COPD. An uncommon genetic disorder called alpha-1 antitrypsin deficiency is sometimes associated with COPD. Although respiratory infections such as influenza and pneumonia do not cause COPD, they can make people with COPD very sick. Therefore, it is very important to keep these vaccinations up to date. At first, COPD may cause no symptoms or only mild symptoms. As the disease progresses, common symptoms include shortness of breath, wheezing, and chest tightness, especially with exercise, and an ongoing cough, often with a lot of mucus. As COPD symptoms worsen, breathing requires much more energy, and it can get harder to exercise or do routine activities like getting dressed or climbing stairs. This may lead to fatigue, weight loss, and muscle loss. People with COPD can experience a variety of symptoms. Different stages of COPD range from mild to moderate to severe. In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult. COPD is the third leading cause of death in the United States and affects more than 13.5 million Americans. It is predominantly diagnosed in middle-aged individuals older than 40 years and is present in both women and men. Although COPD is more common in men, more women die from this disease each year than men. The rate of COPD continues to increase worldwide due to smoking and worsening air pollution. While there is no cure for COPD, you can take steps to feel better, stay more active, and slow disease progression. COPD can be managed by consulting early with your healthcare provider, seeking diagnosis and intervention therapies, and adopting lifestyle changes that include quitting smoking, pulmonary rehabilitation, healthy eating and exercise, and maintaining a positive outlook.
Maintaining a positive outlook.
That's not
Why not do that when it's everybody else's fault? Shitty life.
All right, top three reasons of death in the United States, and it's practically preventable.
I believe that.
Interesting.
People don't, man.
Pretty much. Smoking.
Okay.
All righty. Asthma.
Oh my God. Asthma is up 300% or more, I believe, right now. I'll have to double check that. Don't quote me on that. It's also up in urban areas. So it's all such thing as you see more animals with asthma too. No one knows why.
Probably second.
That's probably global warming.
They get little inhalers too.
Yeah, with spacers. You see the spacers for the tigers, man. They're like call it out at portable 2 tables. So, what is asthma? Asthma is a spasm of the upper airway passages. Yeah, Amazon passages is there. It's the area, but you can't blow the air back out. And it's from inflammation of your airways that develops mucus, which makes it even worse. And that mucus plugs the airways. Signs and symptoms: tripod, wheezing, dyspnea. Question.
So how come the air can come in, but it can't come out? If there's mucus there, wouldn't it not be able to come in either?
Well, it can't come in also because the air is already trapped in there, so you can't get the volume out, so you can't get air in also.
I see.
But it's the trapping effect, like a one-way valve is what, because the way the inflammation works, the way your airways work, is more like a one-way valve. So the air goes in, but it can't go out, so you can't take more air in because the pressure is already there.
I see.
Because remember, the way we breathe is we expand our chest, so it makes less atmospheric pressure. Well, air is trapped, now you don't have less of atmospheric pressure. Because the pressure from the atmosphere going in and out is how we breathe. Any questions? Tripod, wheezing, and shortness of breath, also known as dyspnea. You gotta know what dyspnea means. Difficulty breathing. I've had asthma my whole life, but I can tell you, it's not fun. Do not order it off Amazon. Any questions? Also very true. It's like my asthma as an adult, like I got over it when I had it as a child. Then I didn't have it again for years as a young adult. I didn't have any asthma problems. And then about 35, 36, when life started really slowing down for me, I started gaining weight again. I started getting exercise-induced asthma. So I've been able to knock that out by, I don't even need steroidal inhalers anymore, just by doing regular exercise every day. Now, granted, I don't do enough exercise to lose weight, but I do enough to stop exercise and induced asthma. Also keeps you from having type 2 diabetes too, which I've never even come close to. But all the doctors think I should. Like, you meet every marker, you're the perfect candidate. But when they do my blood work, I do the fasting blood work. I'm not kidding, my blood work's a straight line when they go look at the lab charts. It's like, hi, you got the blood work of a 20-year-old. It's like, yeah. You don't look like this blood work. You should see the 20-year-old kid I gotta pay to go in and have blood drawn for me. It's costing me a fortune.
Asthma is a chronic long-term condition that can be managed but not cured. Asthma affects the airways of your lungs. It causes the airways to narrow and swell, resulting in wheezing and difficulty breathing. During breathing or respiration, air goes in through our nose or mouth to the upper airways, at which point it reaches the windpipe, which branches into 2 large bronchi to reach the lungs. The lungs are protected by the rib cage, which also contains the muscles that control your breathing. In asthma, the airways are oversensitive and easily irritated by certain triggers, called asthmatic triggers. Most people with asthma are described as atopic, meaning they have an allergic type reaction to external triggers, such as house dust mites, pollen, cigarette smoke, animal fur, and chest infections. However, for some people, the onset of asthma is unpredictable and may be caused by anxiety, stress, or even laughter. An asthmatic trigger causes the airway walls to swell and the muscles around the airways to contract. The airways narrow, and breathing through them produces a whistling sound called wheezing. Mucus is produced from the lining of the airways, which clogs up the narrowed airways further and causes coughing. This makes normal breathing more difficult, producing symptoms of asthma that can be mild, moderate, or severe and life-threatening, where hospital treatment is needed. The narrowing of the airways is reversible if the trigger is removed, or if the inflammation is treated medically. Therefore, preventative treatment is used and can be managed by the patient themselves. An acute asthma attack requires medical intervention, but the type of intervention depends on the severity of the attack. For more information, visit www.nhs.uk.
American asthma attacks are a lot different. It's a joke, I'm just kidding. All right, congestive heart failure. So just heart failure is a cardiac condition. Why are we talking about it in respiratory emergencies? Well, here's the reason why. It presents shortness of breath, and that's the complaint is dyspnea. Severe dyspnea. This is a terrifying condition. And you as a provider, when you actually get to see someone in CHF, it's a terrifying thing to see. So this is when the heart, the left ventricle, is not able to adequately pump blood to all the cells to life. So you're thinking, wow, cardiogenic shock, right? That's what cardiogenic shock is. But you're actually not quite there yet because the body compensates and retains some sodium inside the kidneys, and it vasoconstricts. So your heart only knows it's failing, so it vasoconstricts. So it increases the pressure that the weak ventricle can't pump. So your blood pressure goes way up. So does your heart rate. And generally, it's the left side that fails first. So he's having trouble pumping blood to the body, but the right side's still pumping. So where's that gonna cause a backup? Lungs. Exactly, your lungs. Your lungs start filling with fluid from the blood backup, from the traffic jam coming out of your left side of your heart. Okay, so now you've got high blood pressure, tachycardia, difficulty breathing, and now you're having gas exchange because there's a bunch of fluid. You're having always can't exchange gas. And you're gonna start hearing bubbling when you listen to lungs out here. It's called rails. Not good. So the second stage of it, it's gonna cause the right side to fail. Right side's only gonna go keep it, because now you've already got compromised coronary arteries, which just caused a heart attack in the first place, which is weakening the left ventricle. Now the right ventricle is gonna start to fail. So the right ventricle starts to fail, you gotta increase the blood pressure even more, because now you can't get blood to the lungs. So it starts backing up. So where does blood that goes to your right atrium, where does that blood come from that's gonna back up into? Pulmonary vein. No, pulmonary veins between the left atrium and the lungs. Vena cavas. So you have a superior vena cava and an inferior vena cava. So it backs up the superior vena cava. What drains into the superior vena cava? Where's the blood get to the superior vena cava through what? You're pointing at it. Yeah, jugular veins. So your jugular veins start to swell. Just like when you have compression of the heart from tension pneumothorax, it's the same thing. The blood's gonna back up out of the right atrium and you're gonna get swelling of the jugular veins. The other thing, the inferior vena cava is gonna have the same thing going. But the inferior vena cava, it's not gonna back up upwards, it's gonna go down. So where would all that fluid accumulate from the inferior vena cava? To your feet. Feet. To your feet, your ankles start to slow. You have a thing called pitting edema where you stick your finger into the skin of their ankle, you pull it out, and the indentation of your finger is still in there. It's called pitting edema. Yeah, it's not good. So, signs and symptoms of congestive heart failure, hypertension, tachycardia, rails, jugular vein distension, pitting edema. There will be test questions on all these respiratory things. You gotta know what they are. And if you know why they're that way, which like I just explained to you, then you're more likely to know the signs and symptoms, right? It's critically important to know why you're doing something and why things are the way they are. Because if you know why and you understand the physiology of it and you understand why it is that way, you're more likely to correct it the right way. Whereas if you're just learning blind terms, blind signs and symptoms, you're less likely to do the right thing and say, oh, what difference does it make? So you want to hear a good example of that?
Yes.
It has nothing to do with EMS or fire or anything, but it's the exact same example. So when I was a wee tyke as an adult, I worked at Respiratory Forest Products here in Wheat, which is a veneer mill, which makes plywood. So I was trained as a grader, and one of the big things as a grader was if a knot on a piece of veneer is more than 1.5 inches in diameter, it's a D grade. And if it's less than 1.5 inches, it's a C grade. So you've got boards coming out of a dryer because they peel the wood off the log, they dry it, splice it, then you grade it and then send it to another plant in Oregon, have it glued together, and that's what makes plywood. All right, 1.5 inches and less is C, 1.5 inches or more is D. If it's over 2.5 inches, then it's what they call shop wood. It's just scrap. Who cares, right? So if it's 1 5/8 inches, you throw it in the sea, it's really not that big of a deal, right? You know, I mean, yeah, it's close enough. And when you got, 50 to 100 boards a second coming at you, you gotta decide what it is and throw it in the right cart. If you miss a couple, it's no big deal. So anyway, after a couple of years, no one else was stupid enough to become a supervisor there. So I went, I'll do it. More money, 50 cents an hour more. Hell yeah. So they put me to train to a supervisor. So the first thing is they took me up to where they'd actually glue and press the deer from weed up in Riddle, Oregon. Giant, huge plywood building. So the first thing they take us is into this giant room that's about 10 times the size of this entire building and about 4 floors high, but it's an open warehouse room. And it's filled with smashed plywood. broken up, smashed, complete waste plywood that they're putting into a chipper. Said, wow, that's a lot of wasted product. They go, yeah, it is. Yeah, this all came from wheat. I was like, really? Why is it so screwed up? They go, it's missed grades. It's like, well, what do you mean? I said, well, if a knot's over 1.5 inches and it's labeled as C and it goes into the press, the amount of glue in there explodes inside the press. So every missed grade, that's what it looks like. So I said, well, you know, I think if people knew that, they might be a little bit better at grading because they knew what the end result was. But when you just tell them 1.5 inches goes in this card, over 1.5 inches goes in that card, people are a lot less likely to do the right thing. It's no different with EMS. Any questions? Anyway, that's the reason why it's so important that you know why you're doing it. You're way more likely to do it right if you know why, instead of just blindly doing it because Brian said so.
A healthy heart, as seen here, beats approximately 60 to 100 times a minute, providing oxygen-rich blood to the rest of the body. Lower left chamber of the heart, called the ventricle, is the main pumping chamber. There are many different conditions that can lead to congestive heart failure, including a prior heart attack, high blood pressure, and coronary artery disease. Any of these can prevent the heart from efficiently pumping blood to the rest of the body. As a result, the heart may beat faster, and the ventricle may increase in size, becoming an even less effective pump. Kidneys sense the reduced blood flow. They attempt to compensate by retaining more water and salt. This excess fluid retention often causes congestion in the tissues and results in swelling and an increased strain on an already weak heart. The progressive effect of the heart failing to properly circulate blood and congestion due to fluid retention is known as congestive heart failure.
So what are the signs and symptoms of CHF? So by the way, CHF stands for congestive heart failure. So dyspnea, which means shortness of breath. High blood pressure, tachycardia, rales, gentle rate distension, fetal edema. That's your classic congestive heart failure presentation. You don't see it as much as you used to. But when you do see it, you gotta act quickly. Guess what? So my entire time being an EMT and the first 75% of my paramedic career, we didn't have this one tool that we have now. We have a tool now that you as EMTs can use that will literally stop, it won't fix congestive heart failure, but it will stop all these signs and symptoms and put them at a stable level literally in a split second when you use the tool. Any idea what tool that is? CPAP. Why is that? Well, think about what CPAP does. CPAP puts you into a higher atmospheric pressure, right? 5 to 10 centimeters of water pressure above the atmospheric pressure. So what does CPAP do? It opens your lungs up, right? So it pneumatically forces the fluid from the rails back out to the vascular space. What else does it do? It immediately gives all that extra pressure, interthoracic pressure, puts pressure on the heart, squeezes the heart, lowers the blood pressure. So they get full oxygenation, get rid of the rails, and lowers their blood pressure immediately. Now, if they have their own nitroglycerin, you can get an order from the base hospital to give it. You throw a couple nitroglycerins under their tongue before you put the CPAP on. That also gives them massive vasodilation and the CPAP. They're like, wow, I feel 100% better. You're a miracle worker. They say, oh, really? Watch this. You take the CPAP off. It's like, don't do that. Keep the CPAP on all the way to the hospital. Make sure you have enough oxygen. That's the downside to CPAP. If you're on a fire rescue or you don't have a giant big tank in an ambulance, CPAP is going to burn through your O2 quick, so you better have spare bottles ready. Any questions?
Yes. How long would that keep you alive?
CPAP?
Yeah.
I don't know. So the problem is you can't stay on CPAP for too long because when you have the constant extra high pressure on your bronchioles, your alveoli, you start rupturing alveoli. Yeah, which is the Bronx studio, it's called barotrauma. So it's a temporary solution to get you to the hospital, get them on medications like nitroglycerin or long-term vasodilators, blood pressure meds to correct it. Yeah, it's not a long-term solution, it's a very short-term, so I would say not very long. Yes.
How would you tell if that was going on?
That start getting chemotypsis and start coughing up blood.
Okay. So,
Like I said, but you're talking a couple days though.
oh, okay.
Yeah, you'll never see it in units. Any questions? All right. Next. All right, spontaneous pneumothorax. Unfortunately, my model's not here this morning. I have a spontaneous pneumothorax model. He was here all day yesterday, helping us. But so spontaneous pneumothorax is when your lung collapses without trauma. Just spontaneously blows a hole in the lining and goes. It predominantly happens, it's prejudice. It is. The majority of your spontaneous pneumothorax patients are tall, thin Caucasians with blonde hair. Usually have a little bit of a sunken chest. Yeah.
Good thing I don't have blonde hair.
Yeah, because he was probably hyperventilating or not hyperventilating, but using a large amount of lung volume, and he popped a seal. It's a hereditary thing for that DNA group. I usually have Talon stand up and walk around the room. Talon is the poster child. I used to be, so that's why I gained weight. EMS is the best thing to stop me from ever having to have a spontaneous demo. Caused me to lose my hair, gain weight, never had that problem. But just to show you how much diet and exercise, go ahead.
No, you go first.
No, wasn't important.
Oh, I was just gonna ask what qualifies as fair skin?
White,
Oh,
Caucasian, extremely Caucasian,
oh, okay.
like Northern European.
Oh.
Yeah,
Do these people?
you're worried now, I know.
Like sunken.
Yeah.
Yeah.
Yeah, those guys, for some reason, get spontaneous pneumo. It's like 90% spontaneous pneumos for people with that DNA, that genealogy. So. So I'll give you an example of this, going back to chapter 2, the first week of class, we talked about health and well-being of the EMT. This is not an exaggeration, I'm not kidding, I kid around with you guys a lot. This is true. So to give you an example of what happens to you if you are not careful. And I have pictures to prove this if you don't believe me. So when I started at Mount Shasta Ambulance, I weighed 130 pounds, right at almost 6 feet tall and 130 pounds.
Oh, that's
all right. Yeah, it was. So I also worked at the mill, Rosebud, which is a great calorie burning place. It is. You cannot work there if you're actually working. You cannot work there and gain weight. It's physically impossible. You'll burn. It's kind of like being a hot shot or on a type 2 hand crew. You're not going to gain weight if you're kept in line for a living. Same thing working, actually working. Not everybody works. But anyway, we went on strike in 1989 for 4 months. And Mount Shasta Ambulance was fantastic owners. They immediately put me on full time there. So I wouldn't have spent. I didn't need to work. I was a young single guy with more money in my bank accounts. I knew what to do with a brand new car and a brand new truck. But I was happy to work full time as an EMT. In that 4-month period, working in EMS full time, I went from 130 to 185 pounds. 55 pounds in 4 months. Huh?
From the drug stop diet.
Or just live and eat pizza, wait for somebody to die, you know? So, and when the strike ended, I went back to work at the mill. And that's why I'm cancer was I never lost that weight back. I maintained. So then in 92, I went back to work full-time for the ambulance permanently. I've been there ever since that. I've been working there since 87, but nonstop full-time since 92. I immediately gained another 40 pounds in less than 6 months when I left Roseburg again. And I've steadily gained about 4 or 5 pounds a year ever since. So if you're not careful and you don't stay on top of your diet and exercise, and you're working even fire, you'll go all the fire unless you're a wildland on a hand crew. If you're on an engine, you really got to watch it. Look at your captains and stuff, your battalion.
Yeah, they got.
I mean, if you're not doing it,
Yeah, it's the mustache that hides it.
yeah, you got to get that porn stash going. I didn't just say that. You got to get the big bushy mustache going. That's the appropriate term. Huh? Slice that a little bit out. All right. So anyway, the signs and symptoms of a spontaneous pneumo. First of all, if they look like a spontaneous pneumo person, but a sudden onset of chest pain and dyspnea. Any questions? Oh, and the other thing too, that's a huge factor if they smoke. And they don't know why that is, but smoking and having the hereditary disposition.
It's up, hail, voices, battery.
Yeah, as a matter of fact, I've actually brought guys in with spontaneous pneumonia to the ER, and they've got a chest tube put in and felt so good that they've taken their chest tube and their water seal outside of the ER to sit down on a bench outside in their gown and light a cigarette. Yes.
What can you do to help prevent that from happening?
I have no idea. Well, do what I did, but I don't recommend
Dye
it
your
either.
hair. Show your hair.
I have no idea. You're not a candidate.
No, my buddy is.
Your buddy is, yeah. I don't know because it's like I said, it's more of a genealogy thing. All right, so this one's not a fun one to talk about. Can't even joke about this one. Pleural effusions suck. This is when you develop fluid between the pleural lining, which the lining is the sac that holds your lungs in, and the surface of the lungs that slowly crushes your lung. Pleural effusions come from a disease process. Rarely, once in a while, you'll get like an infection or something that causes it, which is good because that can be cured with antibiotics. More often than not, about 90% of the pleural effusions I find end up being undiagnosed lung cancer. Or you guys have probably seen the commercials for it. Another type of cancer called mesothelioma. And that's what kills you about mesothelioma is the pleural effusions. You'll see those,
Medical asbestos.
Yeah. Well, same thing. So that probably over 90% of mesothelioma is caused by exposure to asbestos. It's never all. Like I had a friend that died from stage 4 lung cancer who never smoked a cigarette in her life or had exposure to asbestos. Sometimes there's other things that cause mesothelioma and cancer, but the majority of the times, yes, mesothelioma is from exposure to asbestos. So what they do now, used to be they go in, so you can do what's called a pleural tap. So they'll go in right in, they'll do an x-ray or a CAT scan, they'll see exactly what the large fluid buildup is. And just like we talked about for but yeah, the thing with the fluid in the heart, the pericarditis causes it. Cardiac tamponade, thank you. Just exactly like doing a pericarditis. That's what I'll think of the head pericarditis is. They do what's called the pleural tap. It's the exact same thing, where they go in under the rib and they tap the pleural lining and they pull the fluid up. And then they can breathe again, but within a day or two, so the fluid comes right back. So a lot of times now they're buying a few months for mesothelioma patients, so leave the pleural tap in and it'll drain into a bag. So it's constantly draining. Buys some time, makes it more comfortable. No happy endings with this. No happy endings.
Hello, this is Dr. Carlo Ojet, emergency physician and founder of edexitvideo.com. This video is about pleural effusion. A pleural effusion is a buildup of fluid between the layers of tissue that line the lungs and the chest cavity. As seen in this picture is the blue area on the bottom left of the picture. Your body produces pleural fluid in small amounts to lubricate the surface of the pleura, the thin tissue that lines the chest cavity and surrounds the lungs. A pleural effusion is an abnormal, excessive collection of this fluid. There are two types of effusions. Transudative pleural effusions are caused by fluid leaking into the pleural space. This is caused by increased pressure in or low protein content in low blood vessels. Congestive heart failure is a common cause. Exudative effusions are caused by blood vessels like inflammation, lung injury, and drug reactions. Symptoms of an effusion include chest pain, cough, fever, hiccups, rapid breathing, and shortness of breath. However, sometimes there are no symptoms. Signs and tests. During a physical examination, the doctor will listen to the sound of your breathing with a stethoscope and may tap on your chest to listen for dullness. The following tests may help confirm a diagnosis. A CT scan of the chest will show a loculated pleural effusion you can see on the left side of the chest. A plain chest x-ray. In this picture, you can see the heart is blunted by this white density on the left side of the chest, the right side of the picture. This is pleural fluid. Pleural fluid analysis. Examining the fluid under a microscope to look for bacteria, amount of protein, and presence of cancer cells. A thoracentesis is the procedure by which we put a needle into this cavity to drain the fluid. Treatment of a pleural effusion aims to remove the fluid, prevent the fluid from reaccumulating, and treating the cause of the fluid buildup. A therapeutic thoracentesis may be done if the fluid collection is large and causing chest pressure, shortness of breath, or other breathing problems such as low oxygenation. Removing the fluid allows the lung to expand, making it easier to breathe. Treating the cause of the effusion then becomes the goal. For example, pleural effusions caused by congestive heart failure are treated with diuretics, water pills, and other medications that treat heart failure. Pleural effusions caused by infection are treated with antibiotics. In people with cancer or infections, the infusion is often treated by using a chest tube for several days to drain the fluid. Complications of pleural effusion include a lung that is surrounded by excess fluid for a long time may be damaged or injured. Pleural fluid that becomes infected may turn into an abscess, also called an empyema, which will need to be drained with a chest tube. And the pneumothorax, which is air in the chest cavity, can be a complication of the procedure done to drain it. If you are diagnosed with a pleural effusion, but the underlying cause has not been identified, then it is most important to follow up so more tests or procedures be done. If you have fever, chills, increasing shortness of breath, chest pain, or feeling faint, if you have any new or any progression of the symptoms seen the first time we evaluated you, you should come back to the emergency department. For more videos like this video, please go to edexitvideo.com. And remember, these are educational videos and should never.
All right, so we talked a little bit about this before, status epilepticus. Actually, not pronounced that way. The status epilepticus is a constant seizure that never stops, or multiple seizures in a row in a very short period of time. And if you have prolonged seizures, you will have hypoxia. This is probably one of the most terrifying things to watch. Any questions? No questions. All right. Pulmonary embolism. Amazingly enough, this is a major killer of people in the United States. People die every day of this. And it's a relatively unknown risk. It's like, go, what? What? You know, say it's a blood clot, you're like, oh yeah, I've heard of that. They don't realize how many people die of it regularly. Just here in Siskiyou County, I can't even tell you how many calls I've been on where emboluses have either stroked someone out or killed them with a pulmonary embolus or a heart attack. So this is when a blood clot breaks free from your leg, goes up your inferior vena cava, goes into your right atrium, your tricuspid valve, your right ventricle, goes down through your pulmonary artery, but then lodges and blocks inside the 12 tiny pulmonary embolis. Tiny pulmonary arteries that go to your alveoli, so no blood flow gets to your alveolis. No blood flow goes to your alveolis, no gas exchange. And it's usually not one rogue clot. It's like, I'm a clot, I'm coming here. It's usually like a little asteroid belt. It's multiple little clots. Just start plugging, you start getting all these. They call it a pulmonary infarction. Is the actual term. You probably won't see that on the test. That's what it'll be on the autopsy. These things kill. The fatality rate of a pulmonary embolus you see in the field is outrageously high. I don't have an exact number, but very few of these people survive. And they're usually dead anywhere from 10 minutes to a couple hours where it kills them. So here's the terrifying part of it for people that don't know, and I don't understand how our society doesn't educate people on this. The risk factors. So there are multiple risk factors that can cause this. And like anything else, we talked yet about how no big problem happens from one thing. It's always a combination of small unaddressed things. So I just talk to people who just call me anal retentive. They call me an anal retentive frick, actually. But they call me anal retentive, and I've been told my whole life, don't sweat the small stuff. I've never found that to be true, because it's the small unaddressed small stuff that all comes together at the same time that causes you a big problem. When you have your shit together and all your small stuff's taken care of, you don't have big problems. Well, pulmonary embolus is the same way. So you can have one risk factor, but when you start having 2 or 3 risk factors together, it's going to happen. So let's go over what causes this. Because, well, first of all, we'll go through the video. Then I gotta do some explaining, because it never ceases to shock and amaze me how many people don't understand how many young females die of this every year. And even in this county, how many people have died from it.
If you are immobile for an extended period of time because of surgery, pregnancy, illness, or travel, you may be at risk for deep vein thrombosis, or DVT, a condition where a blood clot forms in a deep vein in the body, typically the leg. Unlike arteries, which rely on the heart to force blood through them, veins transport blood with the help of muscle contractions while you move and walk. Veins also have valves that keep blood from flowing backward and pooling in your arms and legs. When you are immobile for an extended period, your venous circulation slows down. As a result, clotting factors in the blood may cause the slow-moving blood to clump together, forming a blood clot or thrombus. This condition is called deep vein thrombosis, or DVT. Common symptoms of DVT include swelling of the leg or a vein in the leg, pain or tenderness in the area, increased warmth in the skin, and red or discolored skin. In some DVT cases, a blood clot may detach from a deep vein and join the bloodstream. The clot travels from the deep veins of the leg, through the veins of the abdomen, into the heart, and finally lodges in the pulmonary artery or its branches, blocking blood flow to the lungs. This condition, called pulmonary embolism, is very serious and may permanently damage a portion of the lung. If a clot is large, or if there are many clots, pulmonary embolism may also cause death. If you experience symptoms of PE, please tell your doctor or nurse immediately. These symptoms may include shortness of breath, a sudden sharp pain in the chest, a feeling of lightheadedness or dizziness, rapid or irregular heartbeat, or coughing that produces blood. To help prevent deep vein thrombosis and pulmonary embolism, your doctor may require you to do the following. Walk around periodically to keep the blood from pooling in your legs. Wear compression stockings and take anti-clotting medication.
All right. So, again, risk factors. Any one of the risk factors can cause you to have a pulmonary embolus. The more risk factors you have put together, the more the chances are it's going to happen. Risk factors. Biggest risk factors: smoking or any nicotine products. So that includes vaping, tobacco, all that stuff. Why is that? It's because it vasoconstricts. Nicotine is a major vasoconstrictor, so it constricts your vessels. So if you have a clot breaking off and it's going through big vessels, your body has a chance from its own efforts to destroy it and delete it before it gets there. When it's going through a tiny little tunnel, it doesn't have as much chance. Sense? Post-surgery. Post-surgery patients don't get up and move around. They stay in bed for long periods of time. When you're staying in bed for long periods of time, you start getting fatty deposits and fatty collection, usually in your gaps. Sedentary lifestyle, same reason as post-surgery. People that are chronically ill people, truck drivers, people that travel long distances by planes a lot, people that just don't get up and move around. It's the same thing, it starts building it up. Here's the big birth control pills. Birth control pills, how do birth control pills work? What they do is it's basically estrogen. It's an increase of female hormones to make your body think that it's pregnant. Your body thinks that it's pregnant, it doesn't ovulate an egg, so you can't get pregnant because there's no egg to get pregnant. So what in turn happens also, it's not like it only does that, it does all the things that mimic pregnancy. You put on weight, you store fatty deposits, things like that. So when you put birth control pills and you smoke, anyone's ever seen a bottle of birth control pills with a patch of packaging, it will always come in big, bold, black print. Do not use tobacco or nicotine products with this. Because it will kill you. Every year, there are people in this community, I can think of two right off the top of my head, females that stroked out when they were not even 21 years old from using birth control, nicotine, and meth. Throw meth on top of that. That's a major factor.
I was gonna say that.
Well, here's the whole thing though. You've got massive vasoconstriction, your body's storing fatty products, and now you're putting on a massive fight or flight with more vasoconstriction and increased heart rate and force. It's almost going to happen. And some, it's actually just killing. You just get extremely short of breath and they're dead in 10 minutes. This happens all the time. And all you got to do is read the label. But this is one of the biggest ones that I see in my career. It's birth control and smoking. And if you're on birth control and smoking and you're over the age of 40, that's a death sentence. Seriously, it's a death sentence. Recent fractures, because what happens is your body starts healing. How does your body heal? More products of blood, our plasma, red blood cells, white blood cells, you get an increase of what to heal? When the platelets combine together and form. Well, so you get recent fractures, you have surgery for, and then you're sedentary for too long. What's going to happen? You're going to die. Yeah. Exactly. So what they do in the hospital, if you ever visit someone who's been in the hospital for days or nights, you put what's called pneumatic stockings on their calves. There's a little compressor at the bottom of it. It goes, it's annoying as hell. It goes all night long. But that's what it's doing is it's compressing and releasing on the calves to simulate walking so those clots don't form. And one of the biggest things is what used to happen before they had those, again, when I was a wee tank of a paramedic, because we get calls from people dead in the parking lot of hospitals. Because what happens is they have surgery, they spend a week in ICU and then recovery, and then they get up and they walk out of the hospital and start walking towards the clot, comes up, hits her lungs, oh God, I can't breathe, dead. Full on bed combined with clotting factors. And what's odd, it's not on here. Another major factor is cancer and cancer treatment. Because again, you're healing and you're sedentary. When you're on chemotherapy, it's hard to get out and hit the gym. You're not going to, because you feel like shit. It completely kills your entire immune system and it takes the life right out of you. So you have a lot of bedtime and rest time and a lot of increased platelets for healing. Cancer patients are at a huge risk for a pulmonary embolism. Of course, clotting agents. You're taking increased vitamin K, and of course, the older you are, the more likely it's going to happen. So, if you have any one of these, you have a risk for pulmonary embolism. The more of these you have combined together, the higher your risk. You have 3 of them put together, you're a big, serious risk of dying suddenly. That's what it did. This kill you quickly. I've seen cases where we brought people in, and within 2 hours they're gone. Any questions? Yes. Usually, the classic chest pain. First of all, chest pain, shortness of breath, but often leg pain. Anytime you get someone that's got leg pain and shortness of breath, you should immediately have red lights and sirens in your head and be terrified.
We had a guy not that long ago,
Some of the fire department's mom just had that happen a few years ago. It was dead within an hour. Yeah. We see it all the time, but the thing, it doesn't get, it's not like one of those things where CNN's like, the pulmonary embolus death rate is, if they were to do that, people would be like, they'd never do it. But it just, people just don't know it. And it's a major killer. Yeah, now when I went and started discovering that you've been on college, kind of go, yeah, I've seen that a couple times. Happens all the time. Any questions?
why they're promoting like on long haul international flights, people get up and walk around.
Absolutely. And people that are in risk factors, sometimes their doctors will put them on an antiplatelet for the trip.
Yeah.
It was a fact that killed Princess Leia. And she survived an abusive relationship to die 30 years, 40 years later on a plane. Sorry, that was a bad episode 3 joke. Failed. All right, CO poisoning. This is another one that happens all the time. And we are about to go into CO poisoning season. We have CO poisoning season since this County. Alternative heat sources and generators. So carbon monoxide. So your body gets oxygen to the cells via your red blood cells with things called oxyhemoglobin, which is where your hemoglobin, your one red blood cell at a time that goes to the alveoli, it binds with an oxygen atom, right? So that oxyhemoglobin, like carbon monoxide, carbon with an oxygen put together, it likes that 200 times better than an oxygen atom by itself. So we'll choose that 200 times for every 1 time, which is the oxygen. Problem is, when you put a carbon atom with an oxygen atom, it doesn't work in your cells. So you basically become very hypoxic. It's an odorless gas, and it's clear. It is a silent killer. You cannot smell it. You can't feel it. And when you breathe it, it will just kill you. CPR, it doesn't do anything. It's too late. By the time you get to CPR, it's too late. Yep, quantum exhaust pipe. Yep. All the time. It happens all the time. Or motorhomes with generators, same thing. And it blocks it snows so high, it blocks their generator vent and it fills the cabin up with carbon monoxide. So signs and symptoms, when you look for his EMT, bright red cherry, it's like, wow, look at that cool color of red there. So cherry, because it's cherry red. They get a headache. They act like they're drunk. They're real sleepy, lost coordination, slurred speech, and they feel generally ill. And then when it gets to a certain level, it's a point of no return. It's not survival. I'll give you an example. Once on it was 4th of July weekend about, I don't know, 7 or 8 years ago. It was a while ago, not 10 years ago, but a while ago. We got a call for guys, the police chief now, he was a sergeant then, started yelling over the radio, got on the scanner traffic. They need an ambulance for multiple victims right in downtown Mount Shasta in the Rite Aid parking lot. I'm like, what the hell happened? It's like July 2nd or July 3rd in the afternoon. Like, what the hell? And so we get down there and he's got 4 freaking unresponsive bodies in the parking lot that's cops drug out by himself. And what happened was he got called for a drunken public in the Rite Aid parking lot. So he shows up and the guy's stumbling and he's slurring his words. Well, this cop though is actually a very, very good EMT, very good EMT. And he immediately noticed that 1, there was no alcohol in his breath. 2, he was cherry red. And so he started asking, where'd you come from? He goes, oh, we drove all night to get here for 4th of July celebration. And it's so hot, we've been sleeping in our motorhome with the air conditioner on. He looks over, there's a motorhome park, you got Sports and Spirits. So he runs over there and sure enough, his wife and kids are inside. And he can't wake any of them up. So he starts dragging them out and he's yelling on his radio as he's dragging bodies out. And what happened was their exhaust vent for their generator had been blocked. And the entire motorhome filled with carbon dioxide. Fortunately, the dad got out and was stumbling around in the parking lot. And somebody found him and called him in as a drunk. That's an example. This happens all the time though. People start generators in houses or they'll start them underneath the crawl space of houses because they don't want their neighbors to hear. They don't want to bother their neighbors. And the snow will fill up above the bottom of the foundation. And the carbon dioxide's not ventilated, it'll go straight into the house. The one you're talking about, the van, where they parked the van and they just left the van running in a major snowstorm in Mount Shasta. Snow gets a couple feet deep, plugs the exhaust pipe that backs up through the exhaust manifold into the cab of the van. Happens all the time. It's very crazy, but it happens all the time. People use alternative heat. They'll either get their heat shut because they can't afford to heat their houses. This winter, that's going to be an issue because we've shut down all of our drilling in Alaska, and prices for fuel this winter are going to skyrocket like you've never seen. People will start using alternative heat sources. And when they use alternative heat sources, you start getting on carbon monoxide poisoning because they don't have the education of the vent for those heat sources. And if they vent, then they lose the heat that they're trying to generate, and it's completely pointless. So you will, this winter, you will probably see more carbon monoxide poisoning than ever from alternative heat. We actually had in Dunsmore once, we had someone bring a space heater into an apartment building and was trying to heat the hallway of an apartment building with the propane tanks and everything. It was like, oh my God, it's like 12 apartments. It's like, what were you thinking?
We had a haul a guy out of the mining claim last year up off Ramshorn. He parked his truck up against a snowbank and was running I don't know why, but he was running a gas heater inside his vehicle, and I think he got a little too warm and fell asleep. It ran probably for a day or 2, and then we went up and found him. And he was not red anymore.
Dead. Long since dead.
Yeah, it's the first time I had seen the heat.
I've been exploring out there for years. I've never
I
come
don't
across
go
one
out
of the
there
mines.
anymore because of that incident. That one freaked me out.
I've been trying to find those mines for years. I can't find them.
It's just along the Trinity River on the East Fork.
On the East Fork?
Shitload of it.
Yeah.
Every winter at the gas station, I meet people. Stay there, it's the stuff in their car,
In the snow.
piled up.
Yep. Common.
Everywhere.
Yeah, the biggest one I had, we actually had an MCI once in Dunsmere. We had it was a house. It had a guy, his wife, his mistress, and 8 kids living inside the house. And he didn't pay the power bill. The power wasn't even out. And so they were running the house on a generator. And the 2 teenage boys decided they wanted to play video games. So they fired the generator up at 1 o'clock in the morning and they slid it underneath the house, non-vented, so they could play video games. And the dad was on the third floor. He woke up with a splitting headache. And he didn't know what was wrong, but he knew something was wrong. Couldn't wake up the 2 adult females inside the house with him. Drugged them outside. There was like 3 feet of snow outside, but it had actually blocked. Maybe it was blocking, but not blocking. Anyway, ended up dragging them out. All 8 kids, including the 2 teenagers, were out cold. Got them all out somehow. And we had 4 ambulances on. It was a full-on MCI. Somehow, all 11 of them survived.
Wow.
Yeah, kids got yanked though, because they were living in a house that the front door, you couldn't even shut the front door. There was no latch. Yeah, and no power, and power had been shut off. So they'd shut the water off. And yeah, it should not have, not a great environment for kids. Yeah. Any questions? Matter of fact, it was where the fire was the other night. You were talking about the same street. Those big Victorians there. Yep. Because that's perfect for large families. That's why I grew up in there. My dad worked here, but when you got 5 kids, where are you gonna find a house to put 7 people in? Dunsmere. Yeah. And how else could you afford them? All right, MRSA. Again, pay attention because this is critically important. MRSA is one of the most poorly understood things in the healthcare industry. I don't know why. It's not difficult. It's not hard. It's not complicated. But for some reason, EMTs, paramedics, and nurses can't understand or grasp what MRSA is and how it works. MRSA, by the time you guys are done with your ride-along settings, or if you're on the fire department, or you do 12 hours in the ER, probably that's exaggerated. Within your first 6 months of working in emergency services, you will be a MRSA carrier. But your immune system will kill it. So it's not a big deal. That's good. So, and that's where the problem is you'll have people like nurses and paramedics, EMTs who go, yeah, I know I'm a MRSA carrier. My immune system kills it. What about it? Well, here's what about it. Here's where the problem is. So when you guys get exposed to MRSA, you will kill it. Literally, you'll kill it fast. Your immune system can easily kill it unless there's something you're severely immunocompromised from something else, you will kill it. So where MRSA becomes a problem isn't with you. It's when you pick up someone with an active case of MRSA. MRSA is a flesh-eating bacteria. So when you pick up someone that has an active case of it, it spreads like wildfire. So everything that that patient touches is MRSA positive. You're going to be MRSA negative because you'll kill it. It's not a big deal with you. Outside of you'll have active MRSA on your clothing, you'll kill it with gloves. Here's where the problem is. If you don't disinfect yourself, your uniform, and everything in your ambulance after a positive MRSA patient, and then you respond on another call to someone that has a compromised immune system, you will kill that patient. They will get that active MRSA. They will not be able to fight and kill like you will, and they will die from that case. That's a big deal. So when someone's MRSA positive, it's a huge deal. The answer is not big deal. I'm MRSA resistant. It's not about you. It's about your next patient. So when you have a MRSA positive patient, you have to disinfect yourself and everything that patient has touched. Gurney, linens, equipment, everything. Any questions? And in the hospital, do they still use fluorescent stickers in the hospital? Right? You know, do they still use fluorescent stickers in the hospital for MRSA? Used to be like a bright purple pink.
Yeah.
They would label things MRSA. So that way, even the dumbest of dumb people can't spread it. Yes.
So you say that we carry it but don't have it. What is the difference?
So we carry it. What happens is that we'll kill it in a reasonable amount of time. It won't, a positive MRSA exposure, our immune systems know how to kill it because we've been exposed to it so many times. We'll kill it. So
Okay,
we're a carrier, so we'll have it on us and it won't affect us. But so let's say
like
Todd, let's say Todd has lupus or an immunocompromised disease. And I come over here and I get MRSA and I touch you and I take your pulse, your blood pressure, and I've got active MRSA on me. No big deal. I'll kill it. It's not gonna hurt me. Then I go over here to Todd, the next call, who's got lupus or an immunocompromised condition, and I start touching him, and I carry the MRSA, and I will give it to him if I'm not disinfected. He died for next day.
Okay, yeah,
Because I
so
didn't bother disinfecting them, because it ain't gonna bother me. So, no, but seriously, you will hear this. It is the most insanely frustrating thing. You will hear medical professionals and some people that are even in supervisory positions will say that, yeah, I'm MRSA tolerant. Huh? In theory, we don't know with COVID. But that is the theory of COVID. But then now they've completely, and I would have still follow the science thing if the governor then hadn't reversed after he fired all the nurses and paramedics, which is why we only have half the nurses and paramedics we used to have. And then, because you used to, if you tested COVID positive, even though you were asymptomatic, you couldn't come to work for 5 days. And if you didn't get vaccinated, you lost your job. And then when we had nobody to work, then he changed it around, put out an executive order that if you're COVID positive but asymptomatic, come to work. Which tells you there was absolutely no science behind that. Yeah, we don't really know. So I honestly, as an educated person and instructor, I cannot tell you if that is correct or real or not, because nobody really knows. We don't have the data and the true scientific knowledge to say if that's what it is or not, because no one's really dealt with it before. We don't have decades of data to definitively say this is this. It's just a wild guess. And they spun a wheel and they threw a dart at it. It goes, yep, everybody stay home. That's what we did. Any questions? Yes. You don't. Lab. So exactly, treat like that's exactly the best thing. When you get done with a call, you disinfect everything. That's how you deal with it. But if you have, what will happen is usually lab at the hospital, we'll find out, it'll come with blood work positive MRSA. And then you just got to make sure. Or if they're in a nursing home, they might be a positive person in a nursing home, and they'll tell you this is a positive MRSA patient. Then you know when you go to the hospital. You don't go in the bed and you report the guy, you're going, oh, hey, by the way, bed 11's positive MRSA. Not good.
Partly one of my questions with that is going is like, we do a ride along, when I've done it, we didn't change our clothes after patients.
Right.
So we disinfect the ambulance, but we're not, it's just the same clothes, so.
Right, or disinfect your clothes.
Yeah.
For yourself, Lysol.
Right.
Yeah.
spray.
Yeah, that's the reason why the COVID, because COVID said that COVID's not an airborne virus. People think masking doesn't work. It's true, it doesn't work. It's not airborne. The reason why you wear a mask is not touch your face. It's a direct example, direct contact. That's why the gowns are so important on COVID, because whatever it touches, something like MRSA will spread it. So that's why you don the gown and the gloves, the goggles and stuff. So in case any droplet or any non-contact or recontact will go on that, you can throw that away when you're done. That's why that BSI is so important. If you know it's MRSA, you're supposed to gown up just like a COVID patient. It's no MRSA. That's the protocol. And if it's not a no MRSA, I mean, if you're never going to be negligent, if someone hasn't been diagnosed with MRSA, they have done that. Usually though, you'll see a very big gaping, infected flesh-eating wound. That's positive MRSA. So, does that answer the question? And as for those of you that laughed about the Lysol bath, for the entire time of 2020 to about 2022, I took Lysol baths daily. I don't have enough uniforms to keep changing. But yeah, after every patient exposure, I also had a kid with cancer, I had no immune system at home. So yeah, so I Lysol myself daily after calls all the time.
Just like a can of Lysol, just.
Yep. Yep.
It says it kills 99.9% of germs.
It does.
What's the difference between MRSA and staph infection?
different bugs. Totally different bugs. Staph is also ugly, but not nearly as, doesn't spread like MRSA does. And staph also doesn't necessarily eat your flesh nearly as fast as MRSA does. Staph will kill you though.
Yeah.
If you got lupus or you're immunocompromised or you're on, or say, if you're a transplant patient. So people say transplant drugs are immunosuppressive drugs to keep your body from rejecting the organ. So anyone that's a transplant patient, staph or MRSA is gonna kill them. Yes.
Where does MRSA come from? Like from a patient standpoint, where would the patient get it from?
From another patient, from a host. I don't know, or it's on a
So it
surface,
just keeps bouncing around.
or they're on a surface, so they're, like I said, they're immunocompromised. So it's the same thing, it also goes down to, so you've got, transplant patients, lupus patients, anyone that's immunocompromised or on immunocompromised medication, or anyone that's chronically ill or in a low socioeconomic setting where they're living in horrific conditions to begin with. Kind of like our friends that we watched in Philadelphia, people that are living in those conditions, your immune system can only fight so many battles at one time. Follow Rome. Roman Empire should have been able to beat anyone. But when they're fighting 7 different wars at the same time, you're gonna get a failure. And then that's how those people get MRSA. And then you go pick those people up and then you go get someone else. That's how the chain goes. Any questions? TB is another one that just spreads like wildfire. Good thing on TB is we can actually kill it with antibiotics. Bacterial, it's not viral. But man, it is contagious. And it is airborne. So you cough up a good thing of a good mist of tuberculosis in a room like this, you're gonna get about 2/3 of the room's gonna catch it. Anyone that inhales those droplets is gonna get TB. It spreads that fast.
That's crazy.
So nursing homes, dorms, schools, subways, anywhere that's a high concentration of people, in a close spot, someone walks in with TB, you're gonna have a problem. That's why they make the TB test before you go do your ride-alongs. Because if you've got a positive TB and you start going into hospitals and nursing homes and stuff, it's gonna be real bad. Kind of like Santa Claus with COVID going into a nursing home. I mean, oh. Yeah. So signs and symptoms, bacterial, it's highly fatal. Before they had antibiotics for it, what they did is they had to move to the Southwest because it doesn't drier and less humid. It grows better in humid, closed confines. That's why I used to recommend people move to the Southwest, Arizona, New Mexico, areas that were no ports, no oceans, no humidity, hot, dry areas that you stay outside a lot because your life expectancy went way up with tuberculosis. You get fever, coughing, fatigue, night sweats, weight loss, signs of TB. It will eventually kill you. So anybody do their homework on that? Find out why tuberculosis is the reason Disneyland exists. Anybody get it?
I think Walt Disney moved there because his brother was infected with tuberculosis.
So there was a
Los
sanitarium.
Angeles.
It was one of the first people to survive and beat it. And his brother, Roy, was the financial genius. Walt was crazy. He was the dreamer that had the ideas. Roy's the one that financed all of it. Nothing in this world works without money. So if Roy hadn't have been in a sanitarium in the Southwest, Walt would have never moved there. He would have never had the financing and the ability to do what he did. So that's why Disneyland exists, because of tuberculosis. Something good comes from everything bad.
Disney also created the first TB awareness videos.
Did they really? See, that I didn't know. And that makes perfect sense.
Yeah.
Absolutely.
1940 something has been the first promoted, like not promotional, but informational video or film, I should call it.
Tuberculosis, how did it say in Tombstone, Arizona? What?
Oh, that's.
You ever seen
that's
Tombstone?
I have, that's with Doc Holiday, right?
Yeah. That's why Doc Holliday was in Arizona, because he had TB. He was the gun that basically they couldn't have done it without him. Any questions? Now that we've got antibiotics that kill TB, none of these things would have happened. It's a good thing antibiotics didn't come till later in history. Something good comes from every tragedy and everything bad. Something good comes from it. You just have to be open-minded enough to look at it and realize it. Huh?
Yeah, a Little Mermaid.
No, and actually, it's true. Every one of the actual Walt Disney movies all are born for tragedy. I mean, the parents always get killed, you know, and or something horrific. James, or not even Disney. James and the Giant Peach. What a horrible starting to a children's story.
Oh, it's.
Yeah.
Who's Doc Holliday?
Who's Doc
You need
Holliday?
to watch that movie. It is so good.
That's your homework now.
Yeah.
It's a big part of American
Tombstone.
history.
Tombstone.
There's a lot of historic movies done on Wyatt Earp. You know who Wyatt Earp is? Wow. Where'd you go to high school?
Medford, South Medford.
They don't teach history? How the West was won? Yeah, rent Tombstone. You can stream Tombstone. I highly recommend it.
Yeah.
It's
It's a very, very good movie and historically accurate. Doc Holliday was a dentist who was also a professional gambler who got tuberculosis and was probably in historical times, if you believe historical times, there's of course a lot of embellishing of the writers, but it was probably the best hired gun in old US West history. Basically didn't miss when he shot. If you drew on him, you shot, you were gonna get killed. Better than Billy the Kid. Sure you've heard of Billy the Kid.
I have.
But anyway, Doc Holliday went with the sheriff Wyatt Earp. They were close friends and was able to take out a gang of people in Tombstone, Arizona. And this big shootout at a place called the OK Corral. It's a big historical thing. So then it keeps Tombstone alive today as a tourism. Just people go to see the OK Corral and all the tombstones in Tombstone. So, but yeah, no, you should watch the movie. They actually said for history and stuff like that, Tombstone is by far one of the best historical, authentic historical entertainment pieces.
I see.
Another good one to watch for historical that you'll learn a lot about, it's about to come out, is Bass Reeves. It'll be out next month on Paramount Plus. Strongly recommend you watch it.
What is it?
Bass Reeves.
Bass like fish.
Yeah. Anybody heard of Bass Reeves? Yeah, you know why? Racism.
Oh.
Seriously. On reality. So Bass Reeves was a slave that escaped during the Civil War, escaped from a general. He was a slave of a Confederate general. This is a historical fact that escaped, went and fought for the North, and after the Civil War was appointed as a U.S. Marshal. But he couldn't read or write. He had no education. And he ended up still to this day has the most arrests of any U.S. Marshal in U.S. history. He arrested over 10,000 fugitives and brought him in and was never injured and did it by himself because no one worked with him because he was black. So the only person who worked with him was he also spent some time with an Indian tribe, took him in. So he had an Indian that used to go with him, and his exploits were so good they actually wrote books about him. And they did a radio show. It was the #1 radio show in America. But then when they turned it to television, they had to change him and made him Caucasian because they didn't figure anyone would watch it because he was black. And it was the #1 television show in America for years. It's called The Lone Ranger.
Oh.
Bass Reeves is the Lone Ranger.
The one that went hunting with Teddy Roosevelt, right?
I have no idea. I don't know about that.
So it's probably the same guy, but he actually took Roosevelt hunting. They couldn't, the whole thing about teddy bears and all that.
Uh-huh.
Took him bear hunting, they couldn't get a bear, and so he tied one up, and he was going to shoot it.
I haven't heard that one, but yeah.
I'm almost on the same.
But anyway, the show's gonna be on Paramount Plus in November, and it's being done by Taylor Sheridan, which is pretty accurate U.S. history. All right, so back to respiratory emergencies instead of U.S. history. Boy, you guys got me off on a tangent on that one.
Yeah.
So pneumonia. So pneumonia is the biggest killer. We talk about all these respiratory viruses. Actually, nobody actually dies from the virus. Pneumonia is what they get secondary pneumonia from the viruses, what generally kills you. AIDS, remember AIDS and HIV was a big thing for decades. It was the #1 killer virus. No one's technically ever died from AIDS. They die from pneumocystic pneumonia, which is a secondary infection from the immune compromise of AIDS. So, what is pneumonia? It's an infection of the lungs. Yep, almost always, if untreated, or unless you have a great way of making a comeback, will result in septic shock. And depending on how healthy you are, it can be fatal. For the elderly, it's a death sentence. Time symptoms will begin with flu and cold-like symptoms. Usually you'll have rails just in the one affected lung, unless you have double pneumonia, which is bad. Believe me, I've had it. It's bad.
You've had it?
Huh?
You've had it?
Yeah. I almost think of being on a call once. Somebody almost said, but I had double pneumonia. I walked over to the doctor's office. It was next door. But they did a chest X. It was like, ah! But I came back to work the next day. I had antibiotics. I did. Get out of our rails with we found out double the warm flesh, wet skin, all the signs of septic shock, severe weakness, and when they cough, they'll be coughing up yellow and green stuff if they have enough pulmonary volume to be able to do that. This is serious stuff. In younger people, they'll usually be anyone that's immunocompromised, has other pre-existing medical condition, or is elderly, the death sentence. Same thing. How many people have died from COVID? Nobody's ever died from COVID-19. It died from secondary pneumonia from COVID-19. That's what it leads to. If you can't get better because your body's trying, your business is trying to fight the COVID, and then you get a bacterial infection in your respiratory system. Bye-bye.
What happened to my grandpa? He had pneumonia, was in a nursing home, and then he got COVID, that was it.
It's over. For elderly people, geriatric people, which would be overweight people, and people with pre-existing medical conditions, it's a death sentence. It's bad. It's real bad. COVID's no joke for immunocompromised people with elderly. All right, here's a video we hope you really like on lung sounds and pneumonia.
There are abnormal breath sounds that you should be familiar with. Snoring, caused by partial obstruction of the upper airway, often caused by the tongue. Stridor, a harsh, high-pitched sound, heard on inspiration, is common during upper airway obstructions. Croup is an example of an upper airway obstruction commonly found in young children and is usually associated with a seal-like barking cough. Wheezing is generally a whistling sound due to the narrowing of the patient's airways from edema, bronchoconstriction, or foreign body aspiration. Rhonchi is a rattling sound heard in the larger airways caused by excessive mucus. Rales are a bubbling sound heard in the smaller airways, typically when they fill with fluid, commonly encountered with CHF and pulmonary edema.
Any questions? Those were actual recordings of lung sounds. That's what it actually sounds like. But it's so important to listen to thousands of clear lung sounds. So when you have a faint ear to that, you go, ooh, that's not right. Super West again.
Hello, it's Wes, Super Wes that is. In this video, I want to discuss stridor. Stridor is caused by narrowing or obstruction of the upper airway. Stridor is wheezing, but it's usually heard during the inspiratory phase. Whereas in this diagram, this is the inspiratory phase and this is the expiratory phase. These little lines denote wheezes. So during inspiration, stridor can be heard without a stethoscope. It originates from around the pharynx and the larynx, so therefore it can be heard during inspiration without a stethoscope. You can hear it standing next to them, and sometimes you can hear it on the exhalation too. The causes for this are croup, that's very common with pediatric patients, along with their barking when they cough. It could be a foreign body in their airway. If they have a nickel in there and it's turned a little bit sideways, that'll cause stridor. It could be a tumor growing in their airway. It could be some sort of inflammation in the upper airway. One example is epiglottitis. There is viral and bacterial epiglottitis. One is very, very dangerous. If you are not sure what the cause of this is, do not inspect the airway. Don't use a tongue depressor. Don't touch anything in your oropharyngeal airway, just so you won't cause any further inflammation or occlusion. The treatment for stridor and its different causes are inhaled corticosteroids, systemic corticosteroids, inhaled racemic epinephrine, or adrenaline. In any situation, stridor is a sign of a serious medical condition and should be seen by a doctor in the emergency room as soon as possible. Okay. Thank you so much for watching. Bye-bye.
Hey, Super Wes. Any questions for Super Wes?
It's Wes. Super Wes, that is. In this video, I want to talk to you about the breath sounds that are often referred to as rales, bronchi, and crackles. Which is which and what do you use for more practical purposes? When you're actually working and charting and giving a report or making a doctor call, this more accurately describes what you should report. Rales and bronchi are outdated terms, and nobody really knows what they mean. The term you should use is crackles. But there's three different things you should include with the term crackles. First, the type of crackles. Are they fine crackles? Are they medium crackles? Or are they coarse crackles? And when do you hear them? Do you hear them during inspiration? Do you hear them during expiration? What part of inspiration and expiration do you hear them in? And where are they in the lungs? Are they right lower lobe? Are they the whole left side? Bilaterally? And that will give you a good description of the breath sounds. Crackles happen when there is air passing through and around fluid and mucus in the lungs, brainstem, bronchus, or upper airway. An exception to that is atelectatic crackles, and of course caused by atelectasis. Atelectatic crackles are fine crackles in the end inspiratory phase, and they're usually in the lower lobes. My diagram here shows inspiration and expiration. Fine crackles sound like Velcro ripping apart. They can be atelectatic crackles, or they might be the beginning of fluid overload or pulmonary edema. Medium crackles are usually scattered about, and the fluid's getting more built up, or there's phlegm present. Coarse crackles usually when there's a lot of phlegm and fluid present. A few notes about crackles. If you hear crackles and you listen to somebody's chest, it's in their upper airway, the nose, or back of the throat, it will echo all through their lungs. So ask them to clear the throat. And also the phlegm's in their chest. Ask them to cough. See if it resolves itself. You don't want to disregard it because they were able to cough it out, but you want to be able to chart that they were able to clear it out. It's saying what the phlegm looked like. Also, if your patient has an endotracheal tube or a trach tube, crackles are not normal breath sounds. They should have clear breath sounds just like everybody else. It just means that they need to be cleared out. They need to cough it up, and if needed, suction it through the tube. So just to summarize, the crackles are either fine, medium, or coarse. Chart when they happen in inhalation or exhalation, and where they're at in the lung. Okay, thank you so much. Bye-bye.
So despite what Super West just told you, terms rails, bronchi are on the test. You need to know what they are.
Oh, yes.
So before you assist someone with their medications, you have to have a base hospital physician order. You have to make sure you have your 75,000 Rs. Any questions? Make sure there's no contraindications. So contraindications for a metered dose inhale. If they are unable to coordinate inhalation, you probably need to be bagging them. Concerned respiratory failure, they're too hypoxic to have the coordination. Of course, you don't give anyone a medication that's not theirs. You don't borrow their spouses or their relatives or their friend. Oh, hey, I got a metered dose inhaler. Oh, yeah, let me borrow that. Not allowed. You got to make contact with medical control. And you got to be can't give more than what's the prescription says. Any questions? All right, next. Make sure you have a spacer. Make sure you have your R's. Put the spacer, coordinate. What you gotta do is you say, when I say now, take a deep breath. And as soon as you press the button, you say now. And that way it propels and then they inhale. Make sense?
A lot of people don't use those spacers.
That's why it's not effective. It's only about 25% effective.
I work in the pharmacy, we have so many people come in and get Benylin and stuff like that, and literally no one can have a spacer.
Yeah.
Like 1 in 100.
Exactly. And I also said over 90% of people I see when I coach respiratory stress, and they're firing that MD out of their mouth, and it's just going straight to the back of their palate, not going into their lungs. They don't.
If the doctors don't give the spacers.
And they don't give the doctors don't give the educations, and a lot of the pharmacists don't give the education when they dispense it. Farmers should hand them basically here. It doesn't work without this.
We would offer it to people, I mean, they were really cheap, and they were
Yeah.
just like, no,
Right.
I don't need that. Actually, we do. No.
Exactly. It will not work without it. And it'll be about 20 to 25% effective, but it'll be 4 times more effective if you use this small, cheap device.
My pharmacist used to tell people to use toilet paper.
Yep,
rolls.
same thing. Will absolutely work. They want to save the 75 cents for the spacer, they can use toilet paper roll, but they got to use the toilet paper roll.
What does that do?
What it does is it's a spacer because it needs space to propel the medication. It takes about that far of distance to propel the medication. So if you're putting it directly into your mouth, all that, the base of the medication sprays directly into the back of your oral pharynx, doesn't get inhaled. Or you put it in the spacer, it has time to propel the aerosol, and then you inhale it all into your lungs instead of going back to your throat.
Yeah, I'd never.
Critically important.
I'd never even heard of a spacer until this class.
Right. So your doctor and your pharmacist have failed you.
Yep.
And I can factually say that. That's not even a debate. They have failed you.
So we're sitting with somebody.
Absolutely.
We try and make a seal like that.
No.
Put it in there.
You just put it in there, try to make a seal at their mouth. You know, when their mouth just have their lips so that it all goes in. But on your end, it's gonna propel forward, so you don't need a rear seal. Any questions? And then, of course, the publisher puts a picture of someone doing it incorrectly. CPAP. Let's go over CPAP. I thought we already went over CPAP.
Yeah.
We did. You wanna go over it again or go to break? Okay, you guys wanna go over it again? All right.
Yeah.
You're gonna have test questions on this.
Can you go back for a second?
Yeah.
I thought you wanna go break.
I didn't, I wanted to do
Person
this.
said yes.
All right, contraindications. You don't put this on people under 8. They don't have the airways rigidity to handle those kind of pressures. You don't put it in someone that's not breathing or is in respiratory failure. You don't put it on people that are dead. You don't put it on people that are severely altered because that means they're already too hypoxic. If their blood pressure is below 90, safely you should probably go 100. It will kill them if you put on CPAP on someone with blood pressure of less than 90 systolic. If they have a pneumothorax, it will make it a tension pneumothorax. You're increasing the pressure. Can't maintain their airway. They have major head trauma, intracranial pressure. What are the signs of intracranial pressure? What do they call it? It's called
Bushy's trial.
if they have facial abnormalities or facial anomalies. Can't put it on someone that doesn't have the contours of the face. What was that Cher movie? Mask.
Yeah, mask, yeah. Great
Yeah.
movie.
Probably would not, that kid probably couldn't get CPAP. Huh?
Cher is in that movie.
Isn't what's the name of that movie too?
Cher.
From 1883?
Yeah, who's the male actor?
Hey, look, comes up here all the time. It's here on Sister County all the time. Jim Carrey, no, I think Jim Carrey was a great school. The dude in 1883, Roadhouse.
Oh, the dude, those killed bacon?
No, not Patrick Swayze. Patrick Swayze's mentor in Roadhouse. The older guy. This guy's still alive.
Patrick Swayze?
He outlived Swept Out. He outlived Patrick Swayze. Like, I think it was
The
dead.
guy that did the wire, Tombstone too?
Was he in Tombstone? Sam Elliott, yeah. Is Sam Elliott in that movie?
Yes.
Yeah.
He's the
He's
badass of the
the,
bike.
yeah, he's the boyfriend.
Yeah.
Yeah, Sam Elliott, that's, yeah. Any questions? Next.
On that, is it, I swear I've seen 100 as well.
Yeah, I go with 100 personally. Depends what, it'll be what your local protocol is. Absolutely not below 90.
On the test, that it's on.
Is it?
Yeah, that's why.
I would go with 100. 100 is safe. If their blood pressure is 100 or below, they don't need CPAP. Something else is wrong.
You go back.
Yeah. I've got serious Doc Brown skills. I can do that.
Just leave the clock tower alone.
What's that? I believe, what does your book say? Nobody's read the book, so who knows? You're supposed to read the book before you come to class.
Pretty sure it's 100.
Yeah. If it's 100 in the book, it's 100 on the test. So you better do what the book says. Doesn't matter what SSB says, doesn't matter what local protocol says. And yes, I stole this from local protocol because that's because National Registry hadn't come out with education on it yet. Probably redid it. The rest of these are pretty much right in line. Intracranial pressure.
The test we will call a cerebral.
Cerebral hernia. And where does it herniate to? Very good. What did you say about it, St. Paul, Bussy?
Yeah, to be there.
I was there. You didn't see that on the internet, on Twitter?
For something else too.
You didn't see the pictures of me and Insane Clown Posse on Twitter? I was there. Oh, yeah. They were highly unimpressed with me because I had no idea who they were. Never, all of them are big dudes.
Oh.
They made me look like Follow the Yellow Brick Road. They're very big dudes. I was like, wow. Let me tell you, getting them out of a rolled over motorhome was not easy. All right. What can go wrong? Hypotension, kill them, pneumothorax. And if you got to worry about corneal drying, that patient's probably doing just fine. They shouldn't be on CPAP in the first place. So it's absolutely ridiculous. Corneal drying, seriously.
What is corneal dry?
That's when your eyes get dried.
Oh.
So saline drops fix that.
Yeah.
Yeah, if you're worried about corneal drying, if that's your biggest concern, you probably don't need that. We're not gonna watch that. All right, respiratory failure. This is one of the biggest things missed on tests and on skills. Remember, tomorrow night, we're gonna start doing medical scenarios. A person respiratory, yes. Question?
No, is this something different? I can talk about it later.
Okay, that's fine. Man, I just dropped my stick. So when someone's in respiratory distress for too long, they're gonna wear out. They're gonna run out of glucose stores. They're gonna be too exhausted to continue. And the respiratory rate's gonna drop. Their SpO2 is gonna drop. The oxygen level of their brain's gonna drop. And they're gonna lose consciousness. They're gonna get soft, relaxed muscle tone. Then they'll get bradycardia. And then, yeah. And that's the order of respiratory failure. There will be test questions on that, I promise you. on the signs and symptoms of respiratory failure. It will be in the midterm. And you guys are gonna be taking the midterm really soon.
Really?
Wait, for real?
Yeah. Soon,
Can we get a study day before we do that?
sure.
Alright.
That's what it was. You want me to give you a study day? It was called last name.
No, I studied my ass off last night.
Any questions about respiratory failure? Yes.
I don't know if you guys are get the answer, but it's less than nice.
In the book?
Yeah.
Oh,
Sure.
Okay.
So it'll be 90 for the test. Thank you. Yeah, if they're below 100, you're going down the wrong path. CPAP should not be your primary. Your primary impression should be something other than needing CPAP. If congestive heart failure and COP exasperation and asthma do not have systolic blood pressures of 100 or less. Those are the only indications. So if your primary impression is not one of those three, you shouldn't be using CPAP. And if they have a blood pressure of 1 or 100, if that's your primary impression, you probably need to reassess. That makes sense? Let's see what you guys have learned. Dispatch to an unknown medical. What do you do first? See a woman sitting on the floor of her home struggling to breathe. She's the only patient. What's next? She's an early 20s female. She can only speak one-word sentences. Airway is clear, but she's breathing 32 breaths a minute, and she's turning blue at the end of her nose and her lips. Is she a priority patient?
Yes.
What's next?
Alright.
You start bagging her, but she's turning blue. Probably a good idea. Well, no history. She can't give me any sample. Well, these slides got out of order. Which, in the olden days when you actually had physical slides in a carousel that could be done, I don't know how that happens on a PowerPoint. Unless someone was up here like when I was on break. Let's move the slides around.
Sorry about that.
Huh?
Yeah.
It's on a cloud.
Oh, never mind.
Operator here.
It's a cloud. I mean, there's nothing to defrag. It's web-based. That way I can give the presentation from anywhere. I used to carry around a USB drive, but I always forget it. They would plug in here. Then we'd have to go to the security cameras, trace back, we take it to the bank. So everything's cloud-based now. I don't have to worry about anything. I can pull up a presentation from my cell phone. All right. Sample. She states she had short of breath during an argument with her boyfriend. She's allergic to antibiotics and shellfish. She takes albuterol and has a history of asthma. Last year, she had a grilled cheese sandwich 25 minutes ago. They had a fight at dinner. He cooked shrimp for himself and a grilled cheese sandwich for her. She became short of breath during the argument, began to turn blue.
Sounds like somebody's allergic to iodine.
Can't get air. Detailed exam. She's turning blue around the lips and nose. She's got accessory muscle usage. Bilateral wheezing with poor tidal volume. She's got a blood pressure of 10,060.
Wow.
Or it could be 100 over 60 with a missing. See, punctuation is extremely important. Any questions? What's your primary impression? Not an asthma attack? No. Yeah, asthma attacks can have an allergic trigger. But anaphylaxis is a systemic reaction, not a local reaction.
Asthma induced by shellfish.
No, she had the grilled cheese.
Oh no, Chris is right. I'm just making him explain himself instead of shooting in the dark.
There wasn't much on that.
All it takes is one drop in an open cup.
Right, I was asking you to explain to me how you arrived at that.
Highly allergic, and
Oh,
she had a
science
reaction
and
like this when I was younger.
Oh, yeah.
History.
Yes, sir.
Yes.
Events leading up to
She's now under response. Look at, so now what's going on? Now what's your primary impression?
Same as my.
Now you have anaphylaxis site symptoms. You did not have that before. You cheating.
You did, they were right there.
So now she's completely red. Her blood pressure is 60/30. They give her some epinephrine, some Benadryl, and some pressors, and she comes back to life. They determined that she, her husband, boyfriend, who was as bright as a train tunnel, cooked shrimp and then cooked her grilled cheese sandwich in the same frying pan as the shrimp. Yes, this really happened. And it happened right here.
I thought she was mad at you for not making your shrimp.
That's what the 911 was called for.
Oh.
Because neither one of them had the education to understand why she was going into full-blown anaphylaxis. And if they had waited about another 2 minutes to call 911, she would not have made it. She was only made it because she got immediate epinephrine, Benadryl, albuterol, and the medic was quickly putting a dopamine drip together because she completely bottomed out. But fortunately, then the epi and Benadryl kicked in. She didn't need the dopamine. Look here for CEs. All right, go to break. Be back at 10 after 10, and we're going to learn about cardiac emergencies. Yay!
Yay.